We'd next like to introduce Dr. Tracy Stecker. She's an assistant professor of community and family medicine here at Dartmouth and at the White River Junction VA Hospital. And Tracy's a national expert in health engagement behavior, trying to help people find their way to treatment who are currently outside of the treatment system. And I think she's going to tell us about one of her current studies at the VA. Is that right? No. Okay. We're going to find out what she's going to tell us about.
Thanks, Bob. So I'm going to talk about an old trial. It actually was done in between 2007 and 2009, and the data was published back in 2010. And I have to admit, I feel like a bit like a goofball if you thought yours was low tech. This trial my technology is the telephone. So I'll just do the best I can to hang with this crowd here today. But I'm going to talk about the trial that we did. That the goal of this study was to get individuals with alcohol use disorders who were struggling with their alcohol use, who had never gone to treatment, into treatment through a CBT delivered over the phone. Everybody in this room knows why we would try and get individuals with alcohol use disorders into treatment. Most do not get any sort of care, so we were trying to get them in. There were two theories that we used that were the conceptual models for this work. It was the theory of planned behavior, which is a theory that talks about beliefs, how beliefs can predict whether or not somebody engages in a particular behavior, and of course cognitive behavioral theory, which is a theory on how beliefs, feelings, and behaviors are all interrelated. Thus, if you change beliefs, you can change behavior, and in this case, it was treatment-seeking behavior. The goal of this study was to see if we could do an RCT to assess whether this cognitive behavioral intervention delivered by phone would result in increased treatment seeking. The sample were 200 individuals who screened positive for an alcohol use disorder using the audit. They were randomly assigned to either the intervention or the control groups. Participants in the control group were just read a pamphlet over the phone about the dangers of alcohol misuse. Participants in the intervention group had a one-time brief CBT session delivered by phone. And then all participants did baseline and follow-up interviews 3 months after their participation to assess them on their beliefs about treatment and treatment utilization. I just said the measures, but we assessed them on their beliefs about treatment. That's the impasse scale. Readiness to change questionnaire, and the treatment services review was used to assess treatment utilization. The intervention is, it takes about 50 minutes to go through a session with someone on the phone. The session is really designed to talk about where that person is right now in terms of their alcohol use, what their thoughts are about getting treatment, and taking them through some of those thoughts in more detail so that they're thinking differently about treatment use. The final step is to make a plan with them. An example, if somebody said during a session that they were struggling with their alcohol use, but they didn't feel like their problem was bad enough that they needed to go to treatment, they might alter that thought to, for example, it would be good to talk to somebody before things get worse, or it's just really hard to admit that I'm having a problem. And that's more the issue than it's not bad enough to seek treatment. Our hypotheses were that people who received the intervention would have more positive attitudes toward treatment and would be more likely to attend treatment. The sample ended up being 198 individuals. Half were male, 3/4 were Caucasian. About half had insurance. The mean age was 40, and they had pretty high scores on the audit. They were compensated for participating in the trial. Results, individuals who received the intervention had more positive, the scale here is backwards, but they indicated they were more likely to attend treatment than people in the control group. They had more positive attitudes toward treatment, although the scale here, it doesn't look like it's significant, but it's minor. It went from like 5.2 to 5.5, so that it doesn't mean much. They had positive attitudes about treatment at baseline, and they just went a little bit higher, but it ended up being significant. Subjective norm, this is back to that theory of planned behavior. These are the idea that important others in your life would be supportive of you seeking treatment. That's not a significant result. People indicated that their family members and friends tended to support them getting help. And perceived behavioral control measures their perception of barriers or facilitators to them getting treatment, and individuals in the intervention group tended to, at follow-up, thought that their scores went higher, so they felt like they had more control over going to treatment than the control group. In terms of treatment engagement, participants in the intervention group were 3 times as likely to attend treatment at the 3-month follow-up than individuals in the control group, but I always point to this, it's 30 versus 10 essentially, so most individuals in the group still did not seek treatment. I have this slide twice, sorry. The most common themes that were talked about during intervention sessions among individuals with alcohol use disorders had to do with the discomfort of seeking treatment. For example, getting help would be hard, it wouldn't be a vacation, it's hard to be intimate and close with people, it's hard to admit to someone I have a problem, and I worry I won't survive detox, it would be uncomfortable. And that was the primary theme, a barrier for them for going to treatment, and in the intervention session we would talk through that fear. The second most common theme was they didn't need help, they like drinking, drinking makes them happy. And the other themes that came up were they can control it on their own, there's a stigma against having an alcohol use disorder, and the idea that alcohol is their primary coping skill. Without it, they don't know how they would cope. An example of a session, this is just one example, is a 59-year-old Caucasian female, and in her session she said, if drinking made me unhappy, I would stop drinking. Drinking makes her happy. Drinking helps her fall asleep, and she just didn't know how else she would relax. And during the session, she modified those thoughts to, well, actually drinking does make me feel unhappy. It makes me feel out of control and less sensible. My mind races when I get exhausted. I could learn other ways to unwind, and other things do relax me. She realized she did have more coping skills than just alcohol. She was not looking forward to going to treatment, but by the end of the session, she decided that she would do it, and she was going to do it for both herself and her daughter. And her plan was to actually go to counseling and not attend AA. So in summary, I hope I made up some time here whipping through this. Participants receiving this type of intervention were more likely to enter treatment, more research is needed, and more work should be done to find a home for this type of intervention. I do want to say to any clinicians in the room, a lot of work might be done by one individual by the time they make it to that first session. So I think it's important in a first session to acknowledge maybe the years of work that individual went through to finally get to that first session. Just take a moment to acknowledge that. And that's it.